In the name of Allah, the Beneficent, Merciful, previous session we talked about agonist, antagonist, competitive antagonist, and also non-competitive antagonist.
Potency and efficacy.
Yes. And a brief discussion about how drug acts, what's the mechanism of action, or what happens after binding of a ligand to a receptor. We said that we have several forms. We have ligand-gated ion channels like nicotinic receptors for acetylcholine. When acetylcholine binds to nicotinic receptors, then we have opening of the channel, sodium channel, entry of sodium, and after that we have depolarization. Okay? Or for glutamate. Some receptors for glutamate are calcium ion channels. For gamma aminobutyric acid, we have chloride ion channels. Some receptors are enzyme linked, and we have two domains, extracellular and intracellular domain for the receptor. And some are GPCR or G protein coupled receptors. Also we have gene activation. For some ligands, we have gene activation. After ligand binds with its own receptor, then we have the transport of the complex of receptor and ligand to the nucleus. Then we have activation of the genes. Then we have mRNA or messenger RNA. And after that we have a special protein. This is the response, or this is the biological effect that we see. See, GPCR. As you know, receptors transfers or passes the membrane 7 times. And the ligand binds with extracellular domain. After that, we have activation of some events. Here you see that we have the receptor, then we have G protein. G proteins in normal situations bind with GDP or guanosine diphosphate. When we have ligand, here you see the ligand. When we have ligand and after binding of the ligand, then GTP can move or displaces GDP. And in this situation, we can have activation of some enzymes, for example, adenylyl cyclase. After activation of adenylyl cyclase, we have conversion of ATP to CAMP, or adenosine triphosphate to
Cyclic AMP.
And cyclic AMP as a second messenger can act within the cell and can produce the response. So we have the ligand, binding of ligand to the receptor, and then we have displacement of GTP and GDP. GTP comes and GDP is removed. In this way, this G protein can activate some enzymes, for example, adenylyl cyclase. And then we have the response. Here you see that we have several forms of GPCR or G proteins. GS. S means stimulator. And some GPCR or receptors are coupled with GS. It means that they stimulate adenylyl cyclase. For example, for epinephrine or norepinephrine in the heart, we have beta-1 adrenergic receptors. And beta-1 adrenergic receptors are coupled with GS. It means that when norepinephrine binds with this receptor in heart, then we have stimulation of adenylyl cyclase. We have increase in the amount of CAMP within heart cells. And CAMP can increase heart rate, can increase contractility of the heart cells, and can increase the AD or AV, atrioventricular conductance. So CAMP within heart cells can increase heart rate, contractility, and AV conduction. Okay? It has stimulation of the heart. Sometimes we have GI, and I is inhibitory. So if a GPCR or a receptor is coupled with GI, then we have inhibition of adenylyl cyclase, and the concentration of CAMP is decreased. Suppose that if for epinephrine and norepinephrine, we have different types of receptors: beta-1, beta-2, beta-3, alpha-1, alpha-2. Epinephrine can stimulate all these receptors. All beta receptors are coupled with GS. It means that each of these receptors can stimulate adenylyl cyclase and increase CAMP. Alpha-2 receptors are coupled with GI. So, epinephrine or norepinephrine is the same, but in one tissue, it decreases the amount of CAMP, while in other tissues, it increases the amount of CAMP. It depends on the type of G proteins, whether we have GS or GI. Sometimes we have GQ. You can see here, GQ. And then we have activation of GQ, then we have activation of phospholipase C, an enzyme called phospholipase C. This enzyme can act on phospholipids of the membrane and can produce two important substances: IP3, inositol triphosphate, and DAG, diacetyl glycerol. So, when GQ is activated, then we have production of IP3 and DAG. IP3 can mobilize calcium from its intracellular storage site. Okay? IP3 can release calcium within cell. And DAG can activate some proteins, some enzymes, like protein kinase C. So, different G proteins and different actions. GS, GI, and GQ are the most important ones. GS, GI, and GQ. Some receptors are enzyme linked. Here you see that we have receptors, and this is the membrane here. We have extracellular domain and intracellular domain. When ligand is present or binds with the extracellular domain, then we have a dimerization. Two of these molecules bind with each other. We have dimerization. When we have ligands or agonists can activate the enzyme. And the intracellular domain has tyrosine kinase activity. So it phosphorylates tyrosine moieties or substrates. And in this way we can have the response. So this is in the absence of ligand or agonist. And here in the presence of ligand. Binding of ligand, dimerization, activation of the intracellular domain, and then phosphorylation of substrates. This is the response. Some receptors for cytokines. You see that for cytokines, again, we have extracellular domain and intracellular domain. When ligand or cytokine is present, then we have again dimerization. Okay? And we have JAK. It can activate a STAT. What's a STAT? Here you see STAT stands for signal transducers and activation of transcription. Signal transducers and activation of transcription. Okay? So we have STATs. STATs can move to nucleus. And then we have transcription. We have production of
proteins,
messenger
RNA, then proteins,
RNA. And then we have
translation, then
protein,
proteins.
special proteins. You have heard about tumor necrosis factor alpha, TNF alpha. Okay? This is a cytokine. And it can activate this pathway. The result is expression of some genes. For example, the expression of COX or cyclooxygenase is increased. Cyclooxygenase is involved in inflammatory response. So, TNF alpha, when increased, then we have inflammation. Since we have increased expression of COX. COX is an enzyme and is a protein that is produced by TNF alpha. This is JAK-STAT system. JAK-STAT system. Some similarity with tyrosine kinase or enzyme linked activities. Ion channels or ligand gated ion channels. You see that the ion channel, which is a protein, is closed in normal situation. When we have the presence of ligand here, we have a change in three-dimensional structure of the channel, so that we have a passageway for entry of the ion. I told you that for nicotinic receptors we have sodium channels, for GABA chloride channels, and for glutamate calcium channels. So this is what happened. Here you see, for example, acetylcholine and entry of sodium. Acetylcholine has a short half-life. You know that. Acetylcholine esterase can degrade it very fast. So, after removal of the ligand, then we have again the closure of the ion channel. We have very fast entry of sodium ions, for example, depolarization. Then we have very fast closure of the channel.
Protons.
So you see that in action potential, depolarization occurs in milliseconds due to fast entry of sodium and fast stop of entry. Some receptors are gene activators. And for estradiol, which is estrogen, for progesterone, for testosterone, for calcitriol, which is the active form of vitamin D, and for cortisol, aldosterone, or adrenal cortex hormones. We have gene activation. Here you see an example. You see the receptor. There is a part which is called HSP90 or heat shock protein 90. HSP90. In normal conditions, when we have no ligand, when we have no agonist, heat shock protein has covered some part of the receptor. When we have the ligand, for example, cortisol, or an steroid hormone, when ligand is present, then HSP90 is detached, is removed. So, when ligand comes, then we have removal of this part. And you see here, this part is DNA binding domain. So, in normal situations, in the absence of ligand, this part or DNA binding domain has been covered by HSP90. After binding of ligand, we have removal of HSP, then we have DNA binding domain. This complex of ligand and the receptor, moves toward nucleus. Then it binds with DNA. And then we have transcription. We have production of mRNA. And then based on the mRNA, we have a special protein. This is the response. So, if you see that, for example, calcitriol can increase can increase calcium absorption from intestine. This is due to calcitriol has receptors in the intestine. Calcitriol enters the cells, binds with the receptor, removal of HSP90, activation of receptor, and then transfer to nucleus. We have a protein as a response, and that protein is calcium transporter. So calcitriol can increase the amount of calcium transporters, and in this way we have more absorption of calcium from intestine.
So removal of HSP90 is in the cytoplasm?
Yes, it occurs in the cytoplasm. This part occurs in cytoplasm, but this complex should move to nucleus to act. Messengers you see here, cyclic AMP, calcium, CGMP or cyclic guanosine monophosphate, IP3 inositol triphosphate. These are second messengers. And this is how agonists can activate GS and how CAMP is produced. Then CAMP as a second messenger can start a cascade of biochemical events within the cell. And here we have enzyme phosphodiesterase. Phosphodiesterase can metabolize CAMP and terminate the action. So this enzyme phosphodiesterase can terminate the action of CAMP. CAMP is produced and can be removed by or metabolized by phosphodiesterase. You know that for calcium, for example, when we have GQ, when GQ is activated, then we have activation of phospholipase C, production of IP3, and IP3 can increase the amount of calcium within cells. In a smooth muscle, when calcium is increased, calcium can bind with actin and myosin, and then we have contraction. This is the response. Secretion of certain substances. And sometimes calcium is important in cell division. You see agonist, receptor, G protein, phospholipase C, then production of IP3 and production of protein kinase DAG, diacetyl glycerol. Diacetyl glycerol can activate protein kinase C, and kinase can phosphorylate the substrates. Is it okay? And then we have IP3. IP3 can increase the amount of calcium release within the cell. Another second messenger is CGMP. Acetylcholine and histamine can release NO from endothelial cells. What's NO?
Nitric oxide.
Yes, nitric oxide. And then NO can activate an enzyme called guanylyl cyclase. Guanylyl cyclase can convert GTP to CGMP. Okay? GTP to CGMP. You know this drug, nitroglycerin, for ischemic heart disease. Nitroglycerin is NO donor, can produce NO or nitric oxide within cells. So when we use this drug or this drug, sodium nitroprusside, these drugs are NO donors. They produce NO. And NO can activate guanylyl cyclase and can increase the amount of CGMP within cells. You know that nitroglycerin is a vasodilator, and nitric oxide is also vasodilator. So when we use this drug, we have production of NO, we have activation of guanylyl cyclase, we have more CGMP, and we have vasodilation in both veins and arteries. both veins and arteries. Here you see a drug, it's called sildenafil. Sildenafil is used in male impotence for sexual impairment. Okay? This drug can cause erectile action. And sildenafil is an inhibitor of phosphodiesterase, a special isoform of phosphodiesterase which is called PDE5. Phosphodiesterase number 5. Phosphodiesterase number 5 can metabolize CGMP. So when we inhibit the enzyme, we prevent metabolism of CGMP. And CGMP in penis can cause vasodilation and erection. So it's used for male sexual dysfunction. We talked about therapeutic window in previous sessions. And we said that in animals we can have LD50, we can have ED50, and the ratio is therapeutic index. Whatever the number is higher, the safety is more. Ratio of LD50 to ED50. This is therapeutic index. Therapeutic index, then it's safe. And low therapeutic index, not safe. And here you see again the formula. LD50 to ED50. LD was lethal dose that kills. And ED is effective dose that can produce the pharmacological effect or therapeutic effect. And the ratio is therapeutic index. Okay, here we have a review. We had agonists, antagonists. What was efficacy? Okay. How adverse drug reactions are produced? Side effects or adverse effects are seen with many drugs. Sometimes for a drug, you have 2 or 3 indications, but you have 200 side effects. If you look at drug leaflets, then you see that, for example, a drug has 2, 3, or 4 indications, but it has several side effects. What happens and how these side effects are produced? Side effects may be classified based on their severity. We have mild side effects, moderate, and severe. A physician don't pay attention to mild reactions. Never mind. Most drugs can cause nausea or vomiting. This is not important. But for therapeutic agents, for cancer treatment, the vomiting may be very severe. So this is important in the case of chemotherapeutic agents when we treat cancer. But in general, many drugs have nausea or vomiting as their side effects, and we don't pay attention. In cases of severe side effects, they may be disabling or life-threatening. For example, when we inject penicillin, anaphylactic shock may occur. This is life-threatening, may kill the patient. We say that injection of penicillin should be done in clinics, in hospitals, to have epinephrine in access, to have oxygen, to have an expert team, to save the patient. We should not inject penicillins in homes. It's very dangerous. 1 out of 100,000 patients may experience an anaphylactic shock, but it's life-threatening and very dangerous. So, depending on the severity, we may decide for a drug how to manage it. Here you see that severe adverse effects or severe side effects are those which result in death, life-threatening, require hospitalization, prolonged hospitalization, cause disability. And these are the classification of severe adverse effects or side effects. We have another classification for adverse effects, and based on this classification we have type A, B, C, and D. Type A is extension of pharmacological effect or continuation of the pharmacological effect. For example, you use insulin for a diabetic patient and you expect to lower blood glucose from high to normal. What happens if the dose is more? We have hypoglycemia. This is the continuation of the therapeutic effect. Another example, you use propranolol to decrease heart rate. For a normal person, heart rate is about 70. Okay? Suppose that we have tachycardia. Heart rate is more than 100. You use propranolol to decrease heart rate. What happens if the dose is more than usual? We have bradycardia. And even we may have heart block. So these are the continuation of therapeutic effect. In type B, we have idiosyncratic or immunologic reactions. These reactions are rare and unpredictable. You cannot predict. We have example, chloramphenicol and aplastic anemia. One out of 40,000 patients may experience aplastic anemia. 1 out of 40,000. This reaction is not dependent on dose, and genetic predisposition can determine whether a patient may experience aplastic anemia or not. So here we have rare reactions and unpredictable. Type D. So type A was extension of pharmacological effect. Type B was idiosyncratic and immunology. Type C was after long-term use. And here we have type D, delayed effects, dose independent, like carcinogenicity, teratogenicity. Sometimes, after several years, the drug may show carcinogenicity. And then Dr. Sandra will continue the class. Here you see that some adverse effects or side effects are allergic in nature. And we have drug allergy or hypersensitivity. Many drugs may cause allergy. And it differs from a skin rash, from urticaria, or severity of asthma. And in life-threatening cases, we have anaphylactic shock. So allergic reactions may vary from small reactions like skin reactions to anaphylactic
Shocks.
The worst form is anaphylactic shock. Here you see that we have different type of allergic reactions to drugs. Type 1, 2, 3, and 4. Type 1 is mediated with IgE. And anaphylaxis is also one of examples of type 1. Sometimes we have less reactions, but they are type 1. In type 2, we say cytotoxic antibody, and IgG or IgM are involved, like hemolytic anemia that is produced by a drug, methyl-dopal. This drug is for hypertension and can cause hemolytic anemia. This is type 2 reaction. In type 3, which is called antigen-antibody complex, sometimes also referred as serum sickness. And we have again involvement of IgG or IgM. Example, propionamide is used for arrhythmia, and it can cause lupus-like syndrome. This is antigen-antibody complex. And in type 4, we have delayed hypersensitivity. Here we have no immunoglobulin, unlike type 1, 2, and 3, which was the involvement of immunoglobulins. Here we have no immunoglobulin, and we have T cells, like contact dermatitis that occur with some drugs. Sometimes we recommend the nurse to use gloves when we want to prepare a drug, because some of them can cause contact dermatitis, and if the drug splashes on the skin, it can cause dermatitis. In this slide, you can see type 1 reactions. In type 1, drug acts as hopten. You know that. Most drugs are not protein and have small molecules. A drug may bind with a protein in the body, and then we have a complex of drug and a protein of the body. Then this protein is different. It has drug. And the body reacts against this protein. The body thinks that it's a foreign protein. So antibodies are produced against this complex. Some drugs can produce IgE. Then IgE can bind with mast cells. We say that in this case we have sensitized mast cells. Mast cells that have IgE on their surface are called sensitized mast cells. In next contact, antigen and IgE make complex. Then we have entry of calcium ions into mast cells. And in mast cells, we have some granules or vesicles containing histamine. So, after binding of antigen, we have exocytosis and release of histamine and other mediators. They cause allergy and allergic reactions. So, first we have binding of a drug to a protein. Then we have IgE against this complex. Then we have binding of IgE to mast cell surface. In this case, we say we have sensitized mast cells. Next exposures, next contacts with the drug can cause release of histamine and other mediators. Sometimes little amount of histamine is released. So we may have a skin reaction. Sometimes the amount of histamine released is so high that it can cause anaphylactic shock. So, a skin reaction to anaphylactic shock, both of them have the same nature, but depends on the amount of histamine that is released. Reactions. In type 2 reactions, which is called also cytotoxic reaction. Cytotoxic reaction. Here you see, suppose that we have red blood cell. Okay? Here we have a red blood cell. In cell membrane of red blood cells, we have proteins. Drug may bind with this protein. Okay? So, drug can bind with the protein. Against this complex of drug and protein, we have antibodies. Antibodies of IgG or IgM. So, here, antigen is fixed on, for example, red blood cells. And we have antibodies. Here, these are antibodies. That these antibodies can bind with the antigen on the surface of red blood cells. What happened later? We may have complement activation, which results in hemolysis. We may also have phagocytosis by white blood cells. So, the red blood cells in this case is not a usual red blood cell. It has drug and protein complex. So, white blood cells try to eliminate these red blood cells. And in this case, we have hemolysis. I said that methyl dopa, which is used for hypertension, can cause hemolytic anemia. And this is the mechanism. Methyl dopa binding with surface proteins of red blood cells, production of IgG or IgM, and then these reactions, which result in hemolysis. Type 2 allergic reactions. Here we have type 3 reactions, or serum sickness. Sometimes we may prepare serums from horse and use in human. And due to these reactions, it's called serum sickness. The other name is antigen-antibody complex, or type 3 reactions. What happens here? Suppose that we have used a foreign protein, foreign serum, and we have injected into human. Then we have antigen. Here you see that little by little antibody is produced against the foreign protein. Antibodies may be IgG or IgM, like type 2. But here we have another feature. Sometimes here you see the days after injection with vertical axis. Okay, here we have the days. Sometimes we have free antigen and free antibody. Here we have free antigen and free antibody. They can complex with each other. Then we have antigen-antibody complex. Antigen-antibody complex. And antigen-antibody complex can activate the immune system. And we have the reaction. Serum sickness may occur 1 or 2 weeks after injection of the foreign protein. For penicillins, we have both type 1 reactions mediated by IgE, and we have also for penicillin serum sickness, which occurs 1, 2, or even 3 weeks after injection of penicillin. Today, I use penicillin, but after 2 or 3 weeks, I have fever. I have arthralgia, pain in joints. I have myalgia, pain muscles. And these are the reactions. I have used the drug today, but the reaction occurs after 2 or 3 weeks. This is serum sickness. And if you see for a drug that it causes serum sickness, it means that we have antigen-antibody complex. We may have fever, vasculitis, arthritis, or even nephritis. Here you see how vasculitis occurs in type 3 reactions. Type 3 reactions. These are antigens. And these are antibodies. And you see the complex of antigen antibody or circulating immune complex. You see that this immune complex can bind with the endothelium of the vessels. And then we have activation of white blood cells. It causes the reaction. And the reaction will be vasculitis or inflammation of the vessels. If it occurs in nephrons, in kidneys, we may have nephritis. We may have nephritis. So all of them are serum sickness or immune complex reactions. Type 4. Here you can see blisters on the skin. Okay?
Yes.
This is contact dermatitis. When drug can contact with the skin. Here we have no antibody. Unlike type 1, 2, and 3. Here we have a delayed hypersensitivity reaction, or type 4. In general, we have different ways for production of adverse effects. And now you can see that how we have a wide range of adverse effects. Sometimes 200, 300 adverse effects for one drug. Some are allergic in basis. Some the continuation of the effect. Some delayed effects. Some after long-term use. Okay? Here again, we have a brief discussion that I said continuation of therapeutic effect, like hypoglycemia of insulin. We may have receptors in different organs. Okay? Dr. Sadrai will discuss that. We have muscarinic receptors in muscarinic receptors in eye, in exocrine glands, like lacrimation, salivary gland, sweet gland, Okay? We have muscarinic receptors on smooth muscles in intestine, stomach, in bladder, vessels, in respiratory tract. Okay? We have receptors in heart, receptors in CNS. So, we have a wide distribution of muscarinic receptors in the body. Suppose that you use a drug to activate or inhibit muscarinic drugs in heart. The action on all other sides will be side effect. No. Suppose that you use the drug for a stomach. All other effects will be side effect. So, a drug may have receptors in different tissues. And when we use the drug, it acts in all of them. So we have a wide range of side effects. Sometimes, drug may act on different receptors. Do you know diphenhydramine? Diphenhydramine. Diphenhydramine is used for cough. And it's antihistaminic drug. Diphenhydramine has antagonistic action on H1 histamine receptors, on muscarinic receptors of acetylcholine, and also on alpha-1 adrenergic receptors. So a drug can act on different receptors, and we have a wide range of side effects. And as I said, we have allergic reactions, 4 types of allergic reactions. Sometimes drug may cause side effect in special populations. Do you know G6PD deficiency? A disease called Favisi. Have you heard about it? Favisi. This is G6PD deficiency. And we have some types of beans. In Farsi, we say bagela. Have you heard bagela or bagali? Bagela is a type of beans, broad beans, and is used sometimes in polo or in rice.
Lubia, in Urdu lubia.
Yeah, it's like lubia, but it's a little.
Just like a kidney shape.
Here, you see that if we have a lubia, then it's bagela. It's a little big. Okay. It can cause hemolysis. When we have G6PD deficiency, G6PD is glucose 6-phosphate dehydrogenase. This enzyme is very important for protection of red blood cells. And genetically, some patients have deficiency of this enzyme. One of my children has G6PD deficiency. It's genetically determined. In G6PD deficiencies, some drugs can cause hemolysis. For example, in antimicrobial drugs, we have sulfonamides. And all sulfonamides can cause hemolysis in a special population when we have G6PD deficiency, glucose 6 phosphate dehydrogenase deficiency.
Then they have hemolytic anemia.
Yes, it causes anemia, hemolytic anemia. Sometimes drug interactions may cause a problem, side effect. So, at this time you know that why we have a wide range of side effects or adverse effects for one drug. Okay, thank you so much for your attention. Sometimes adverse effects are associated with long-term use. For example, we say that corticosteroids can cause osteoporosis, but not after 1 week, after 2 doses, after 3 weeks. Several months, several years of drug use may cause osteoporosis, especially in those patients which are in risk. For example, post-menopausal women. In post-menopausal women, we have some worriness about osteoporosis of corticosteroids. It occurs after long-term use. If I use a high dose of insulin, then short after that I have hypoglycemia. But here we have long-term use. So some adverse effects occur very fast. In anaphylactic shock, it occurs very fast. And the team should be ready to use very fast oxygen to inject epinephrine. To save the patient. It occurs very fast. But here we have long-term use. If a patient says that I have used 2 ampoules of dexamethasone, a corticosteroid, then I have osteoporosis. We cannot accept because it's after long-term use.